Good evening, and thank you for joining us for another installment of our Ask a Doctor series. I'm Titania Bailey, president of Arc of Knowledge, Inc., a nonprofit organization that provides resources towards building and strengthening relationships between our youth and seniors. And as part of our generational health and well-being initiative, we have the pleasure of partnering with MedStar and Centerpoint Baptist Church to provide education and resources that promote better health practices. Before I introduce our speakers, just a few quick reminders to keep your devices muted throughout the presentation, and all of our questions can be entered into the chat and will be addressed at the end of the presentation during the question and answer portion. Tonight's session will feature presentations by both Dr. Oliver Tanous and Dr. David Weiner. Dr. Oliver Tanous is an orthopedic spine surgeon at MedStar Washington Hospital Center. As a spine specialist, he utilizes state-of-the-art, minimally invasive and motion preservation techniques to treat conditions of the bones, discs, and nerves of the neck and back. His clinical interests include disorders of the cervical spine, ranging from isolated disc herniation to complex deformities and bell surgeries. He has a special interest and focus in cervical disc replacements and motion preservation of the neck. Dr. Tanous completed his undergraduate studies in neuroscience and behavioral biology at Emory University. He then received his medical degree from the University of Maryland School of Medicine, where he completed a residency in orthopedic surgery. Prior to joining MedStar Health, he completed a fellowship in spine surgery at the University of California, San Diego, a leading center for minimally invasive and complex spine surgery. His early interest in mechanics and how things are built, coupled with a degree in neuroscience, fueled his decision to become an orthopedic spine specialist. Dr. Tanous takes a conservative approach to spine care. He emphasizes the use of non-operative treatments before considering surgery. When surgery becomes necessary, he utilizes minimally invasive techniques in order to reduce the impact of surgery. He has extensive experience in revision spine procedures, as well as correcting previously failed spine surgeries. Please welcome Dr. Tanous.
Okay, thank you so much. Can everybody hear me well?
Yes.
Okay, I'm going to share my screen here. Okay, do you see the notes or is it just the slide?
I see the slide.
Just the slide, perfect. Okay, well, thanks for having me, everybody. I'm excited to be here and to talk to you about what I'm going to focus on, mostly probably just the neck and then cervical spine motion preserving procedures. Dr. Weiner then will follow, and I think we'll address other components of the spine and musculoskeletal system. So the objectives of my brief talk this evening is, number one, I would love for everyone to understand the common causes of neck pain, because I'm sure most people on this Zoom have probably experienced it at some point in their life. To understand how to treat, but more importantly, how to avoid neck pain. And then third, to understand when to need to see a spine surgeon if surgery is necessary. But I think the bulk of what I'm going to talk about is going to be non-surgical, because I think that's where people really benefit the most from the information. And so this is my philosophy. This is what I tell my patients. Yes, I'm a surgeon, but I treat the vast majority of my patients non-surgically, because the reality is that the body has an incredible capacity to heal. And when you address that capacity to heal, people tend to do really well. And even when patients come to me and I know they're surgical candidates and I know they could potentially benefit from surgery, I still usually try to continue non-surgically, because number one, it allows me to get to know people better. Number two, sometimes you're able to avoid it, and that's really important. However, when it comes to the spine, the caveat is when people have neurologic deficits, meaning weakness that's getting worse, bowel or bladder changes, or severe intractable pain that's just not compatible with daily living, that's when you usually have to talk about surgery sooner rather than later. But thankfully, that's the minority of our patient population. So briefly, I just want to revisit the spinal column. So in the spine, we have four regions: the cervical, which is the neck; the thoracic, which is the upper back, that's centered around the rib cage; the lumbar, which is the lower back; and the sacrum, which is essentially part of the pelvis or the tailbone in colloquial terms. And if you look at the image here on the left-hand side, you can see that the spine has four curves, and those curves balance each other out. And I'll get to that later as to why we sort of evolved with a curved spine as opposed to a straight spine or a different structure. But the function of the spine is, number one, to allow us to stand upright as humans. We're the only humans in the animal kingdom that live in a bipedal state, meaning on 2 feet rather than on 4 legs. And number two, to protect the nerves that travel through the spine, because that's our central nervous system that controls our body. But what I remind people, and my patients especially, is that what surrounds the spine is this incredibly powerful, robust network of muscles. And it's the muscles around the spine that allow us to stand upright, that allow us to move, that allow us to function. And they're very powerful muscles. Imagine what it takes to carry your body weight upright all day, every day, throughout your entire life. You have to have very powerful muscle groups to do that work. Well, the problem is as powerful as they are, when they function well, things are great. But when they start to dysfunction, that's when they can become incredibly painful. And we'll talk about that, because the vast majority of neck pain that people experience tends to be muscular in nature. And so on one hand, that's a good thing, meaning people come to me and they're afraid that there's something terribly wrong. And then usually I'm appeasing their fears and letting them know that I think it's probably muscular. But then the bad part of that is that it usually takes a lot of effort to improve muscle pain and stiffness. So what are the main causes of neck pain? So we already said, number one, deconditioning of the muscles in the neck and around the shoulders. Number two is stiffness and strain of those muscles. So when the muscles get weak, they can become painful. But if they remain in that weakened state for too long, they start to contract and they become stiff. And those are two different things, because when someone has, let's say, whiplash injury from a small car accident, they can go and get a massage or start some therapy and they can reverse that really quickly. But if people live with neck pain and stiffness for years, it takes a lot longer to reverse that. And that's a different type of physical therapy that people need. The third common cause is degeneration of the small joints in the neck, usually the facet joints, which are small joints in the back of the neck that the muscles attach to. And that's basically arthritis, but not necessarily bad arthritis. Arthritis just means degeneration of a joint. And the hallmark of that is it makes people feel stiff, especially when you wake up in the morning or after you've sat for too long. But thankfully, that can be treated with physical therapy. The fourth cause are pinched nerves. And typically when people have a pinched nerve in their neck, the pain will travel into the neck, around the shoulder blade, and then down the arm. And then sometimes with numbness and tingling or weakness in the hands or in the arms. And then the fifth cause of neck pain, the fifth common cause of neck pain is disc degeneration, which is a different type of arthritis, but similar to the facet degeneration that I talked about in point number 3. Now, we tend to focus, when I say we, meaning the medical community, people with neck pain who get imaging, x-rays or MRIs, there tends to be a huge focus on the discs. And that's because you get a report, and the report oftentimes has a lot of big words and is lengthy and says things like disc disease, degenerative disc disease, disc degeneration, and they use all these big words like spondylolisthesis or spondylosis or neuroforaminal stenosis. But the bottom line is that disc degeneration for most people is normal. And one of my favorite studies was the study that was actually done here in Washington, D.C. in the 1990s. And they were trying to figure out, this was in the early days of MRI technology. Back then, it wasn't common to get an MRI because it was in the early stages of adoption. And they were trying to figure out what these MRI findings meant. And what they did is they took people right off the street and asked them if they'd ever had neck pain or arm pain in their life. And they said no. These are people who said, nope, I've never had neck pain in my life. And they said, perfect, come on in. We want to get an MRI. Let's see what your neck looks like. And they got 63 individuals, and they found that overall, 20% of these people had a very substantial abnormality, meaning not just a little bit of this, a little bit of that, but a very substantial abnormality on the imaging. They found that in the patients less than 40, about 25% of them had a degenerative disc. In the patients who were above 40, 60% had a degenerative disc. And then actually newer studies have now shown that patients above 60, about 95% of people above 60 have a degenerative disc in their neck, meaning arthritis. And again, these are patients who have never had neck pain in their life. And so the conclusion here is that just because you have disc degeneration or just because you have something on an image doesn't necessarily mean that you're going to have pain. In fact, most people don't. And so that's what I tell my patients. I'm not here to treat your image. I'm here to treat you and to try to figure out how to make you better. And we can live with degenerative findings because that's the process of life. We get older, things deteriorate, but doesn't mean we have to feel bad. And so this is my algorithm. This is how I think every single patient that comes and sees me in clinic, this is how I think about it. The first question I'm going to ask you is, have you ever had physical therapy? And not just physical therapy 3 or 4 years ago, meaning have you had physical therapy in the past 6 months? And if the answer is no, then that's definitely where we're going to start for neck pain, because people get better with physical therapy. It's incredibly powerful when you start to deconstruct the stiffness and the weakness and the muscle contractures, how much better you can feel. And for most people, that process tends to happen pretty quickly. However, the important thing is that once you start to feel better, you can't just stop. You have to keep going, and it has to become part of your life. And that's what I tell my patients is if it's important, you do it every day, just like brushing your teeth or washing your face or any daily routine. If it's important, you do it every day. Other treatment options can be things like anti-inflammatories, which are the Advils and the Aleve and the Motrins. And those can be very beneficial short-term. Long-term, you want to be careful. They can have some side effects. And that's it. 90%, I'm not kidding you, 9 out of 10 people with severe neck pain. These aren't people who are coming in with a neck strain. These are people who come into a surgeon's office and they're concerned because they have severe neck pain. They think that something's terribly wrong. 90% of them get better with PT and maybe some medications. And if they don't get better, then maybe we send them to a non-surgical specialist to try some injections, and that can certainly help a large majority of those patients with remaining pain, and then surgery as a last resort. So again, the vast majority of patients with neck pain get better without surgery, unless there's a neurologic deficit. So when people do come to me for a surgical evaluation, meaning they've already had the physical therapy, they've had the injections, they've been through everything, then it's up to us to try to figure out, can we help you with surgery or can we not? And in general, and I'm sure Dr. Bueno will touch upon this with the lower back, but with the neck in general, we're not good at fixing neck pain with surgery, meaning the neck pain that people have in the back of the neck, that doesn't always get better with surgery. So I tell my patients, do not do the surgery for your neck pain. When people have a pinched nerve and they have the shooting pain down the arm, or they have a compressed spinal cord that's resulting in neurologic changes like loss of equilibrium or loss of hand function, those are conditions that we're very good at treating with surgery, and those tend to be really good surgical candidates. So those are the two main conditions that we treat in the neck. We treat pinched nerves that result in the equivalent of sciatica. Sciatica is a condition for the lower back and the legs, but it's a radiculopathy. It's a pinched nerve that results in arm pain, weakness, or numbness, or spinal cord compression. And those are the two most common conditions that we treat with cervical surgery. Now, over the past 60 years, meaning since the 1950s, 1960s, this surgery right here, the anterior cervical discectomy infusion, the ACDF surgery, has been the gold standard for treating cervical conditions. And the reason it's been the gold standard is because it has had traditionally very high success rate compared to the rest of the spine procedures out there. Meaning everybody here, I'm sure, knows somebody or has heard of somebody who has had a spine procedure. Usually it's the lower back, with not great results. And a lot of that is patient selection. I think there's a newer generation of surgeons who are learning more advanced patient selection techniques and understanding who can potentially get better and who can potentially not get better. But part of it too is that anterior cervical fusion is a relatively minimally invasive procedure. It's a small incision from the front of the neck. And it's a procedure that allows you to effectively decompress the spinal cord and take the pressure off the nerve. So this is a procedure where people tend to wake up and their symptoms are gone. And it has a very high success rate. Well, the problem with a fusion, I'm sure everyone here has heard the term fusion. The word fusion simply means joining two things together. So in this image, you can see here that a disc was removed. And the reason to remove the disc is to take the pressure off the spinal cord or to take the pressure off a nerve. And once you remove that disc, you can't leave it alone. You have to replace it. Otherwise, it would collapse. So when you replace it, the historical standard was to put a piece of bone. You can see here, this is what the bone looks like. It's an allograft. It's a piece of allograft bone. And then to put a plate and screws and stabilize it. Well, the problem with that is that when you lock up a motion segment, meaning when you fuse a disc, you're still moving. The patient's still moving. The patient's still living their life. And with daily motion, the stress of that motion will transfer to the disc above or the disc below. So in the cervical spine, there are 7 discs. So if you fuse 1 disc or 2 discs, then with your daily motion, you're going to get that increased stress or that increased motion at the discs above or below. And that term is called adjacent segment disease. And this is what it looks like. You can see here, this is a patient who had a fusion between the 5th and the 6th bones in 1970. Things went great. Patient was happy. 7 years later, the disc below degenerated, then had to have the disc below fused. And then 7 years later, the disc above degenerated and had to have that fused. And so what we've tried to do as a spine community over the past 20 or 30 years to try to get around it was to develop motion preserving technology. And in this situation, cervical disc replacement. So in the same way that someone has a knee replacement or a hip replacement, cervical disc replacement technology really began to surface in the United States in the early 2000s. Well, the problem with this in the early 2000s, meaning 20 years ago, is that there were some catastrophic failures in the early stages of technology. These things were not doing that well. However, just like all technology, it improves over time. And now 20 years later, we have a lot of really good implants on the market that are surviving 20 years or longer since we've been tracking them. And this is what it looks like. This is an X-ray. You can see this is a neck X-ray. This is one of my early patients when I started at Washington Hospital Center. He was a dentist. And he came to me and he had severe arm pain, weakness in his hand. He wasn't able to work as a dentist anymore. And his MRI showed he had 2 pinched nerves in his neck. So he was relatively young. He was in his early 60s, which I consider relatively young. And so for him, I said, let's not fuse you. Let's try doing a disc replacement. You can see here on this image, I replaced 2 of his discs. And you can see when he extends, the disc opens up. And when he flexes forward, that disc closes. And he's maintained full range of motion. In fact, his range of motion was better after the surgery than it was before the surgery, because you eliminate an arthritic disc and replace it with a disc that preserves motion. So this is the reason that the spine is curved, in case anyone's ever wondered this question. So if we were to think of the spine as a spring, things that have a spring-like structure can resist load, right? You can put as much pressure you want on a spring, and as soon as you release that pressure, it's going to go back to its resting state. That's why the spine is curved. If our spine was flat, or if our spine was stiff, this is an example of a patient, not my patient, not anyone here in Washington, D.C. This was a patient in San Francisco who underwent a very long surgery. You can see here screws and rods from the base of the neck all the way down to the tailbone, but things that are stiff, just like a twig, tend to snap. And so that's the reason why our spine is developed in a curved fashion. So these are 3 examples I'm going to show you of what disc replacements look like. This is a patient here who came to me with a compressed spinal cord and pinched nerve. So this patient had weakness in the hands and was losing balance. And if you look here at the MRI, this, I don't know, can you see my my mouse? Yeah, okay. So if you look here at the MRI, this gray line in the MRI is the spinal cord. The white line in front of it's the space for the spinal cord. And up here you can see there's space, plenty of space. But then down here, that space disappears. And so the gold standard, the traditional standard here would be to do an ACDF of fusion on this patient at 3 levels. Well, for this patient, I said, okay, we do need to fuse 1 level because I had to resect too much bone to do the decompression. But I said, you know what? Let's fuse 1 level. Let's replace the other 2 so we can preserve that motion. And that's what we did here. I had to fuse the middle level right here, but I was able to replace the discs above and below. And you can see here the range of motion that this patient has is overall 25 degrees of range of motion with bending and extending at those segments. So you can oftentimes come up with a targeted plan to replace as many of the levels as possible to preserve that motion. This is another patient who's a 50-year-old male who had previous surgery. And you can see here, this is a surgery that was done in another state about 15 years ago and had 2 discs that were fused. And this patient did really well. He did really well for about 10 years. And then a couple of years later, started developing neck pain, weakness in the hands, worsening balance. And you can see on the image, the disc above is completely gone. This patient is bone on bone at the disc above. So I said to him, you know what? We don't have to necessarily fuse the next disc. Let's try to replace it. And so for him, I offered him a disc replacement. You can see I was able to restore between 6.7 degrees in one direction and 7 degrees in the other. That's a total of almost 14 degrees of range of motion I was able to restore from one disc. And then what that does is it ends up protecting the disc above it. So this patient will have a much lesser chance of needing future surgery because that disc replacement protects the disc above it that's still doing okay. This is a slightly different scenario. This is the lumbar spine, but just to show you that you can also do this in other parts of the spine, usually the lumbar spine. And this is a patient who's bone on bone here, the lowest level. This is the L5 level. This is the S1 level. So this is the lower back. You can see here bone on bone. The disc is degenerative and is bulging. And so instead of fusing this patient, I said this was a young female, 42 years old. We did a disc replacement. And you can see here, this is what it looks like. It looks sort of like a knee replacement or hip replacement implant where you have a piece of metal on one end, a piece of plastic in the middle, and a piece of metal. And that combination allows you to preserve motion. And this is the motion that this patient has after surgery of 28 degrees in extension, 18 degrees in flexion. So that's a total of 10 degrees of range of motion, which is a lot of motion to preserve and makes a difference and protects the discs above it. So overall, I think we have finally gotten to a place in modern medicine and with technology where a lot of the traditional surgeries that used to be fusions don't have to be fusions anymore. And the patients are doing really well by preserving the motion because then it protects other levels and it allows a quicker recovery process usually because you're not wearing a brace or a collar or constricted, and the recovery process tends to be a little bit easier. So I will stop here. I'm guessing we should probably just have Dr. Weiner go and then we can do questions at the end, or how would you like to proceed?
Yes, I'm going to do a brief introduction of Dr. Weiner, and then he can get started on his presentation, and we'll do all questions at the end, if that's okay.
Great. Yep.
All right. Right, so our next presenter is Dr. David Weiner. Dr. David Weiner is a fellowship-trained orthopedic surgeon who specializes in spine surgery. His area of special interest and expertise include adult spinal deformities, pediatric scoliosis, body tethering, degenerative disorders, and arthritis of the spine, disc replacement, and minimally invasive spine fusion. Dr. Weiner has been published in several peer-reviewed journals and presented at conferences and scientific meetings. He also takes a conservative approach to patient care and focuses on non-surgical treatment options before recommending surgery. When surgery is the most appropriate path, he works with a multidisciplinary team to ensure patients' needs are met and they have the support they need from diagnosis through surgery and recovery. He works with all of his patients to provide them with the information they need to be active partners in decisions about their care. When he's not working, he enjoys spending time with his family, doing home improvement projects, and playing golf. Please welcome Dr. Weiner.
Can you hear me?
Yes.
Great. Well, thank you for the introduction, and thank you, Dr. Tannous, for doing all the heavy lifting and starting out with some excellent explanations about some basics of what we're talking about tonight. Let me see if I can, oh, I can't share my screen. Are we able to do that? It says host disabled participant screen sharing. Am I able to, there we go. All right, close your eyes before I start here. So, let me see if I can put this into slideshow. There we go. All right, so I'm going to give a brief overview, and I'll skip through some slides here relating to cervical spine that Dr. Chinus already covered. So I'm Dr. David Weiner, like you just heard. I originally from Philadelphia, moved down here not too long ago, about 2008. I did some engineering work early on, followed by medical school at Georgetown, and then my residency up in Baltimore at Union Memorial Hospital, followed by a fellowship in adult and pediatric complex spine deformity at Mount Sinai in Manhattan. So we've already talked about care philosophy and alleviation of pain through non-surgical techniques when possible, and making a shared decision-making process. One of the things that I do a lot of is this deformity surgery and adult arthritis, scoliosis, and we'll talk about a couple differences and what that means. But it is most certainly not a surgery or a surgical specialty that is right for everybody. And just because you have scoliosis or you were told you have scoliosis as an adult, I would say, just like what Dr. Tanu said, the vast majority of patients should not get a surgery because of the undertaking it is. And sometimes, as we say, the cure is worse than the disease, and it's a long recovery, and we should really be really good about selecting the right patient. And that decision comes through a shared process with the patient and myself, determining, do we really want to move forward here because of what we're talking about doing. So let's skip here. So let's talk about some lumbar stuff, some lower back things. Very common. Everyone's heard of a slip disc or a pinched nerve in the back. Well, here is an MRI. This is what we're going to look at in an office together after usually going through physical therapy and seeing how well you respond. 90% of disc herniations will not be a problem. In fact, one of the biggest studies that was ever done in orthopedics was, and in spine surgery, is called the SPORT trial. And that was done in 2013 and then followed up a multiple number of times. And that looked at disc herniations. And there was a simple question, because we were operating on a lot of these, is, do we need to operate on disc herniations? Some people do really well without surgery. And it seems like if we just wait, we do okay. And they followed two groups of people who had surgery and people who didn't have surgery. The people who didn't have surgery would get injections and physical therapy and acupuncture and kind of do just heat, ice, things that you can do at home, take anti-inflammatories, and those who had surgery. And it turns out that, with a couple caveats, at 2 years out, whether you had surgery or you didn't, you were exactly the same level of comfort at 2 years out. So why should we ever do surgery on anybody? Well, it goes back to what Dr. Tanus was saying, which is, do you have a neurologic condition? Is there something that is profoundly wrong where you can't use your leg or your muscle, or the pain is so bad that you can't possibly function with that level of pain? And that's when surgery makes sense. So I would say it's very rare, probably for myself or Dr. Tanus, that we meet somebody and the very first time we meet them, we book a surgery unless there's something catastrophic going on. And so for somebody like this, we usually will send them to get injections and physical therapy. And only after they've failed and proven that they're not going to tolerate that do we proceed with surgery, because we know that usually it's just going to be okay if you give it enough time. So if it does come to that, we have very minimally invasive ways of doing this. So this is called a tubular microdiscectomy. It's a surgery done through a small little portal. It is about, it's less than an inch of a cut. We do this as an outpatient, which means that you come in the morning and you're home by lunch. This CAT scan you see on the right side shows you a hole where the bone gets removed so that we can access the disc that has kind of herniated out. That size of hole is about as big as your fingernail. So we're talking really small things, really small instruments, very minimal disruption. The vast majority of people don't even take any pain medication, or if they do, they're only on it for a couple days. This is one of those surgeries, just like Dr. Tanus was saying with the ACDF, that is, you wake up and the pain is generally gone. Most of the time we do the surgery for leg pain. Excuse me. And if you have leg pain that's caused by a nerve that's being pinched, once that nerve is no longer pinched, that pain goes away. So this is a very satisfying procedure for not only the patient, but for us, because it's such a fast relief and such a successful endeavor. And, everybody wakes up and usually says, I can't believe I didn't do this sooner. But again, we know that given enough time, most of these patients will do very well left alone. I'm going to skip through this ACDF talk because Dr. Tannous covered that very well, and the disc replacement talk. I'm going to move into some more deformity. So I'll very briefly cover this, which is neck deformity. So when you have somebody or have a patient who can't hold their head up, so things can get so bad where you can no longer maintain eye contact with somebody, or look up to shake their hand and have all kinds of issues with driving, turning your head. Sometimes we really can't do and get away with motion preserving, and we need to kind of accept the fact that the spine structure is no longer able to perform the function it was designed to. And so that requires a fairly aggressive approach sometimes. And so here you can see somebody who was having a very hard time lifting his head up. And what we had to do was do a front and then back surgery. And in this case, what we do is we're able to use the bones that are there and use the ACDF in combination with a surgery from the backside, where we can get a wonderful support column to help offload the force that was going through that area of deformity and maintain, although fixed, and although there are problems down the line potentially, maintain a nice correction where this patient is able to keep his head upright. The pain he was having is gone. And although he can't move his neck, he is locked in a functional position and is much happier as a result. This is not very common. This, what we call head drop or neck drop or chin chest deformity, is pretty uncommon. And usually when most people feel something that's developing into a chin chest deformity, we'll seek help first, and we can intervene before it gets that bad. Let's move on to the lower back or lumbar problem. So let's start with a very common one. You may have heard a surgeon say spondylolisthesis. It's a very medical mouthful. Spondylolisthesis is Greek for spondy or spine, and listhesis meaning slip. So in this case, you see on the left side, there's a bone that's very clearly out of place. So this usually happens when the backside of the spine is no longer providing the support it needs. So the analogy I like to use here is, imagine if you stack up a bunch of chairs. If you were to break the back legs off one of those chairs, all the chairs above that broken chair could slide forward. And the back legs, if you can see my mouse, are this part of the bone right here. So you can see there is a break here. If you can see my mouse, you can see there's a break in the bone right there. That's called a pars defect. And a pars defect is very common. Almost 4% of the population has a pars defect that they were just born with, that it's not a problem. But in other cases, it can be caused by just the stretching, just like a paper clip that you bend too much, it'll thin out and stretch. And that's what happens over time with arthritis. And so when that occurs, we end up with this situation where one of the bones or the back legs of the chair either break or bend too far. And then you end up with a bone that can move too much. So somebody like this generally has a lot of pain in the back. And what's more than that is they end up having a lot of pain in the legs because the nerves that exit out behind this bone are getting stretched forward a lot. And so as they get stretched forward, every time you bend forward and stretch them more or bend back and lean into this pars defect, you're going to get pain or pain down the legs or pain in the back. And it's really very uncomfortable. And there's no good way to hold yourself in a stable position. So somebody like this really does benefit very well from a fusion. And so this is a patient I had where we were able to place some rods and screws in and actually pull the spine back into alignment. And it's actually very intentional that these bones are not lined up. And for a variety of technical reasons, we don't want to actually make it perfect in this type of a situation. So we line this up and put a metal implant in the front of the bone of the spine there. And we can actually, in a very minimally invasive way, fish that metal implant in from the backside. So you only have one cut. And somebody like this generally will be able to go home the day after or 2 days after surgery. And as long as they're careful with their back for the first few months, bone will grow between the spine on the backside and through the bones in the front. And so, again, this patient will lose motion. And that's part of this. They're going to feel stiff, but they're going to feel a lot better than they did before the surgery. And the stiffness is the goal. We want stiffness here. The same thing with this. Somebody who has degenerative disc disease, where they have just the disc has worn out, and not necessarily that the back side, the back legs of the chair have worn down. We can put in a spacer like you see here and just raise the height between the two bones and hold them in place. Sometimes we don't need to use a spacer and we can just put the rods and screws in. And the reasons that we would do that versus not do that, or how we would put that in, depends very much on the individual patient, their anatomy, and what the problem is. So oftentimes we don't need to put in one of these metal spacers in the front, and we can get by with just the rods and screws in the back. And I've shown you now two pictures of patients with a one-level fusion. And so let's go on to another really common condition, which is lumbar scoliosis. And so this is something that's becoming increasingly common as our population gets older. This is a condition, scoliosis. Everybody's heard of scoliosis. You know, you got checked for this in school when you were growing up. And scoliosis is usually harmless. And so everybody thinks of scoliosis like a problem where it's an S-shaped curve, where the spine isn't straight anymore and it's creating an S shape if you look at it. Just like we see on the picture here, this is a C shape. Well, in this case, what's happening is that we are wearing down the spine too fast on one side and it's not equal. So just like brake pads in your car, if you use the brake pads a lot, they wear out fast. And as you lose the normal even wearing on your spine, one side wears out faster. And your body, the goal of your body and your muscles is to keep your head centered over your pelvis as much as possible when you stand up. Well, as a result of that, you see that you get a curve where you've worn out one side faster, and then you end up getting a correction back to the center here. And so this patient is experiencing a ton of pain in the back, pain that will not respond to injections or physical therapy. This is a gentleman who loves sailing, and all he wanted to do was go out and sail on his boat, and was not able to do that because of the pain. He couldn't go out or manipulate the jib or his sail because of the amount of pain that even just pulling on the rope would cause. And so somebody like this, after extensive counseling and making sure that there is a good response to injections, at least for a little bit, is a good candidate for a bigger surgery. And so let's stop and talk about this now for a second. So you can see what's happened here. And this looks scary because there's a lot of metal and there's a lot of screws. And this is kind of what deformity surgery is at its core. And this is why somebody needs to be really on board and counseled about what the right surgery is for them, if any, because this is a big surgery to recover from. So here what you see is we have rods and screws that are holding everything together and bringing that curve back into basically a straight alignment. And for a variety of reasons, we don't always want this to be perfectly straight. And you'll see that there are metal implants up front. And you might notice that those implants don't look the same as the other implants that we saw in the last slides. And that's because these implants were put in from a variety of different positions. And that leads me to the next point of what is modern spine surgery? Well, it used to be that we would do all surgeries from the back. And that makes sense because that's where your spine is. And we would cut down and do these big, huge incisions and have a lot of pain after surgery. And it was almost more pain than what you were dealing with before the surgery. Well, now we don't need to do that. So the implant at the very bottom, this one, actually comes in through the belly. So we work with another surgeon to get access to the spine from the belly. And that is not nearly as painful as cutting through the muscle in the back. And so we can do that and get a great correction and get a really reliable fusion by putting that in from the front. And then you'll see these implants above that look really long. And there's a screw coming in from side to side. And that's because that implant comes in through the side. And that is, again, an implant that can go and does not need to have a ton of muscle cut to get to it. And that's really the most painful thing of a surgery, is cutting of muscle. And so if we can find minimally invasive ways to get the spine straightened out without having to cut through muscle, your pain after surgery is much, much less. And that's what these two implants do. These implants help to correct the uneven wearing of that arthritis and scoliosis and don't cut through a ton of muscle. So between these three lower implants, this patient really would not have a ton of pain post-op and could go home very quickly. Now, in this case, because of the surgery that was needed, we had to extend the screws up and down a little bit more. And so there was a bigger cut. But in certain cases, which we'll talk about soon, I don't even need to make a cut in the middle of the back anymore. I can do this all with a robot or with spinal navigation, which is like GPS for your spine, where I can do a CAT scan of your body in the surgery. I can then actually have a computer map out where your spine is relative to my hand. And then there's a computer and a camera that watches my hands and my instruments and can show me where on your spine I am with those instruments. And so I can know within a millimeter where I am. So I can actually just make little poke holes in the skin and get screws down without having to make a big cut. So there's a whole new world of deformity surgery, people with scoliosis who are getting surgeries in a minimally invasive way and can go home within a day or two with pain that is very reasonable. So then we can move on to things like congenital deformity. And there's a variety of congenital deformities that extend beyond scoliosis. And these are much less common. This is somebody who had a what's called a congenital hemivertebra. And his vertebra at the very bottom here wasn't fully formed. And just like you need to have your the curves in your back in a very specific way, like Dr. Tanous was talking about, when it's this flat, we have a big problem. And so by removing this vertebra, I'm able to put in a special cage through the front and remove most of that half vertebra and put like a big car jack in and increase the height. And we don't need to make this perfect. We just need it to be a lot better than it was. And this is somebody who went home 2 days after surgery and had almost complete resolution of the back pain that he was experiencing by 2 weeks after surgery. And that's not always the case, but it goes to show that we have a tremendous capability to improve pain from very specific things through very minimally invasive ways, even in incredibly complicated scenarios. Navigation and robotics, we've talked about this a little bit. This is what I see. When I'm doing a navigated case, I will see a computer model showing me on your CAT scan that we just took intraoperatively, that I know where the screw is precisely and can place it down in real time, watching exactly where that screw is going to make sure that we are being safe and avoiding putting screws in the wrong spot, which is unfortunately something that can happen. It's not common, but it can happen. And when it does, it can lead to very significant problems. To take that to the next step, what you see on the right is a robot. And so we can combine the CAT scan and the robotic imaging that you see on the left side with a robotic arm. It's kind of like if you've ever seen a video of a car being built on an assembly line. There's big robotic arms. It's a smaller version of that. And it will position itself exactly where it needs to be so that I can place the screw down in this trajectory. Now, the robot will not place the screw down for us. We don't want that. Okay, we want to be in control and have the feedback, the feel, so that we know that we're not doing anything bad. And so the robot, when you hear robotic surgery, is not placing the screws. It is an assistant for us as surgeons to be able to put a screw in very safely and effectively without having to make a big cut down the middle. Now, like I talked about, sometimes we do have to make big cuts down the middle. And a big part of my practice is doing revision surgeries. So when somebody had a surgery in the past that didn't go well, going in and fixing that. And that's unfortunately something that happens to this day. But more importantly, as we've learned more about spine surgery and who will do really well with spine surgery, we realize the mistakes of our predecessors and maybe things that we wouldn't do today that were done 15 years ago that are now showing themselves to be a problem. And so you'll see somebody like this, where you can see somebody's had multiple surgeries. And as they go down, this is called kyphosis, or a bend forward too much. This is junctional kyphosis, which is a very specific problem that can happen at the very bottom or very top of a long fusion construct. And this can have many different forms. In this case, the screws were breaking through and pulling out at the very bottom after a surgery somebody else did. And one of the things I want you to notice is that there is a circle here. And I don't know if you are familiar with what this might be, but I'll just tell you this is a pain pump. So this is a pump that is used to deliver pain medication continuously into the spine to help somebody who's dealing with pain that will not get better. And if you look at what's happening on the right side of the screen, there is no more pain pump, because what had to happen was a revision surgery where the upper rods are connected and replaced down to new rods at the bottom. And that is kind of the goal of surgery, is to correct the underlying problem. The pain pump is acting as a mask for this pain. The pain pump is acting as a Band-Aid over the problem. And my philosophy is that we should really be treating the underlying problem, not just covering it up as much as possible when it's safe. And so this is the kind of patient who does, incredibly well, because they may have been on pain medication for a very long time, not just through a pain pump, but through oral pain medication. And once that is gone, once that underlying problem is gone, they no longer need to be on pain medication for the rest of their life. So although it's a big surgery and this patient really can't move their back very much anymore, their quality of life is dramatically better because they're not constantly thinking about their back or missing events that they have to walk too far to get to a soccer game for their grandchild or their son because it hurts too much. Now let's move on to the son or daughter, which is thoracic fusions for scoliosis. So this is a lot of what I trained on, and what I do is pediatric deformity and scoliosis. And so everybody was checked for scoliosis when they were a kid growing up. And fortunately, the vast majority of people do not need to have anything done with scoliosis. It's something that is only getting worse when you grow, and we can usually just put a brace on and everything goes well. Sometimes if the brace doesn't work, or if the curve is too severe, we do have to do something like this, where we do rods and screws. And this is the gold standard care for scoliosis. And it has a remarkable track record, and patients do incredibly well. The problem with scoliosis is that if it gets worse as you get older, if the amount of curvature that you have is too high, you will end up developing worsening and worsening frequency of pain. Your pain won't be worse than your counterparts, your age-matched friends who don't have scoliosis. You just have pain more frequently. And so we do a fusion knowing that we will be helping prevent that in the future. So we do this generally when children have stopped growing. Around 14 to 16 years of age is the most common time that we do it. Sometimes it's a little bit older, but we try and time this in such a way that it's as minimally impactful on their school life. So the fusion is the gold standard. But now we have a new way, a minimally invasive way to do this that is not fusing. So that's vertebral body tethering. So I told you about how the spine is growing. And if we can catch a kid, a child, at the right time, as their spine is still growing, but doesn't have too much growth left, what I can do is go in actually through the chest and put in screws that go on the outside of the curve. You can see this screw is actually going over here. If you look at where the heart is, this goes on the convexity of the curve. Out here, there's a screw going this way and this way and this way. And then we come in on the lower back through the outside, and we put a screw here, here, and here, and here. And what that does is it allows us to harness the remaining growth and put a flexible cord that's affixed to these screws. And if we catch everything at the right time, as the child grows for the next year or two, this cord will hold down the outside of the curve that's growing faster and let the inside of the curve that still has growth left catch up and straighten out. So it's like taking a tree or a long vine and strapping it to a stake and letting it grow straight. It's the same idea. And the beauty of this procedure is that it's not a fusion. And while in the thoracic spine, a fusion is not a big deal because the thoracic spine doesn't move very much. In the lumbar spine, we need to move. That's really important. And so we know that if we fuse children way down low, down to the L4 and L5 level, they have a very high rate of getting early arthritis at the lower levels because it's so much force and rigidity above that level that they will end up having to have something done later on in life. And even the ones who get fused down to L4 and L5, very few of them return to sports. Very few of them return to doing the activities that a child should be able to do. So this is a breakthrough treatment to be able to preserve that motion. And I want to show you a video of a patient that I did with my mentor in fellowship. So this tends to be mostly very active kids who seek out this treatment. This is a girl who is 6 months out from this procedure. That's the kind of thing that you cannot do 6 months, 1 year, 6 years out from a fusion down to L4 like she had. This shows you the flexibility that you create and can preserve through this type of surgery. So we are at a very different level of spine surgery than our mothers and fathers, our brothers and sisters even. We have a totally different understanding of what spine surgery is and what we can do, and more importantly, who we should or shouldn't do it on. So me and Dr. Tannous are generally seeing patients in a very similar area and work together a lot. We're partners and are able to see anybody for any reason and talk through what's going on and try and avoid surgery as much as possible, but are available and have the knowledge base and skills to treat whatever you have going on. So I'll stop there. And I think that me and Dr. Tanous can probably field any questions. I know that was a lot of information, but there is no question too small or too
Mhm.
large. So feel free to fire away.
It's a very informative presentation. Definitely appreciate that. I want to put your information in the chat. If you could send that over to us as well, for our participants to have that. And if any of you have any questions, I have a couple questions that came directly to me, but outside of that, if any of you have any questions that you'd like to um, present to our doctors tonight, please feel free to take yourself off mute and ask them to either of our doctors. So I have three questions that were sent to me. What are the symptoms of a pinched nerve?
I think whether it's the neck or the back, usually the first symptom that people get is either tingling or pain. The pain is usually what starts first. The tingling can happen later. And then in bad cases, it's weakness. But a pinched nerve can happen in the wrist. It can happen in the elbow. It can happen in different parts of the thigh. It can happen around the knee. But when it comes from the spine, main hallmark is that it has to feel like it's coming from the neck. People with a pinched nerve in the neck, it feels like it's coming from the neck and it's traveling down the shoulder, arm, and forearm, and sometimes to the hand. When it's coming from the back, it feels like it's coming from the back and then going down the buttock and the thigh like a sciatica. And so those are typically the symptoms: pain, sometimes numbness, sometimes weakness.
And then the other part of that was, what are the symptoms of spinal cord compression?
Good question. So the spinal cord compression, thankfully, for most people, especially when it's due to arthritis, happens slowly over a very long period of time. It happens slowly over years. In the early stages, what people start to note is they start to note like their hands start to slow down. Their hands start to feel clumsy. The hallmarks are, people will say, my buttons are not as easy. You lose fine motor skills, so buttoning becomes difficult. Putting a zipper together becomes difficult. Opening jars becomes harder. And then people will say, I'm dropping things. I just feel like I'm dropping things all the time. I don't know why. Those are the early stages. At the same time, with the lower extremity, in the early stages, people start to lose equilibrium. They start to feel like they're losing balance. And the best way to describe it is people say, Doc, I feel like my body's drunk. I feel like my legs are clumsy. Like I'm clear, I'm awake, I'm alert, but my legs feel like they're clumsy and they're drunk. Those are the early stages. And then obviously it progresses over time if it's left untreated, and then it can get as bad as being stuck in a wheelchair. But thankfully, the vast majority of people, by the time they're needing a cane or a walker and it's kind of progressing, they're seeing a specialist and we're catching it usually in the early stages.
Is there an age limit for spinal surgery, or is it more the patient's health and quality of life?
Yeah. Dave, you want to answer that one?
Yeah, sure. I don't think there's an age limit necessarily. I think it depends on, what your other health conditions are and what your goals are. So sometimes, like we talked about, the goals of surgery don't necessarily line up with what your goals are for your life. And if you're not trying to be, out there running marathons, then we can avoid surgery entirely, young or old. But there are certain patients who, will not qualify, young and old, because of their medical conditions. Like they may have a history of a stroke or heart attacks or things that are so substantial that even putting you to sleep for anesthesia is too dangerous. But there is no cutoff. It's a very individualized decision, and it's something that is carefully decided between you and your surgeon. I want to kind of roll back and touch though on the spinal cord pinching though. I do think that it is something where thankfully we do catch it in the very early stages, but it's not the kind of thing where if you start experiencing those symptoms that you want to, say, well, let's see if it gets better. I think Dr. Tunis and I have both seen more than we would like to have seen patients who waited too long, or maybe were just kind of on the fence about being seen, and then they had a bad fall, and then things get rapidly very, very bad. And so you absolutely want to say, I think something is maybe not right here, and be evaluated as soon as you can, because you don't want to put yourself in a vulnerable position when there's an easy fix before it gets bad. Because one of the things that we always tell patients is, you've all seen enough movies and television and spinal cord injuries to know that the spinal cord doesn't always cooperate, and the function that you lose, we don't always get that back. And so we want to try and intervene as early as we can to avoid losing function, because if we get to it before you've lost the function, that's great, but once you've become weak, we don't always get that strength back, and we really want to maximize all of your function before it goes away.
What is, I'm sorry, says, what is the biggest challenge? I'm sorry, the biggest challenge you faced in spinal surgery?
You want to go first, Oliver?
My biggest challenges in general are not surgical challenges.
Okay.
What happens in the operating room, I tell my patients, I have complete control over. I know what I'm doing. I know where I want to go with the surgery, and I'm going to get you there. My biggest challenge is everything around the surgery, the pre-surgical discussions, the education, making sure that if you're a smoker, we're coming off the nicotine. If you're taking too much Percocet, coming down on that dose before surgery so that we can control the pain afterwards. Making sure there's a support system, there's a safe environment at home, making sure that people understand that it's not just the surgery, it's the physical therapy that's important. Those are my challenges, making sure that my patients who go into the surgical process understand everything they need to do beforehand, afterwards, and really commit to the rehab part, because that's what really makes someone have a very successful procedure compared to a kind of successful procedure.
I would say for me, it's making sure that we're doing surgeries and patients have the right expectations, and having a really honest discussion about what we can and can't do. And like Dr. Tanu said, we have control over the operating room and what we do in the operating room. But if you come in thinking that this is going to be a fountain of youth, that's not unfortunately very realistic yet. And so having the expectation set and understanding that we're going to do everything we can to address the problem, and your x-rays are going to look great and the nerves are going to be free, but back pain, that's hard to treat, and it may not get better, and you may not get strength back if you have weakness already. And just make sure that we all understand what our destination goal is. I think that's one of the hardest things, just because you need, it's something that you need to come to terms with as our spines start to get older and fail, is that there is going to be potentially some things that we just can't get back. And so just coming to terms with that, not only as a patient, but as a surgeon, that we can't make everything perfect, is hard to wrestle with.
Right. And I'm going to combine these two questions. How many spinal surgeries do you perform in a year? And what is the longest surgery that either of you've ever performed?
Right now, I think I do about 200 surgeries a year. It's we can do about two or three surgeries a day, depending on the day. Some days, if it's a bigger surgery, it's only that one surgery. I have operated for more than 14 hours at a time. on, big fusions where you go from somebody's skull to their pelvis, and it's exhausting. You go out, you have to take bathroom breaks, and you have to make sure that you're preparing for that the night before, getting a good night of rest. But it's it's satisfying and worth it at the end, but those are long days. I don't know. I'm curious to hear what Oliver says about this.
I've been in practice a little bit longer than Dr. Wiener, so I'm currently about 350 surgeries a year, and some are small, some are 30-minute procedures, some are 5-6 hour procedures. I would say the average is about 2 to 3 hours. My longest surgery was 19 hours. There was a patient who had a really bad tumor, and we had to remove the tumor. Then we had to work with the plastic surgery team to take muscle from her belly to fill in the gap where the tumor was. And then we had to move some of her intestines out of the way to safely remove the tumor. So, and then we had to stabilize her spine. So that was 19 hours, and she's done really well, thankfully.
Is that an en bloc resection?
Yeah.
Oh my God.
Poor Doma.
My God. Good for you.
Does going to a chiropractor help with spinal compression? And do ring dingers really help or hurt people? And please explain what ring dingers are.
Yeah, I can answer. I can start, Dave. If you,
Yeah, you go.
so there's basically two types of initial physiotherapy. You can work with a physical therapist or you can work with a chiropractor. There are some phenomenal chiropractors out there, but then there are also some that don't necessarily have the level of training or the standardization for that training. Versus when you go to a physical therapist, you know that that person has gone to an accredited program, graduated with a doctoral degree. That doesn't matter as much. The difference in general, though, is that when you go to a chiropractor and you get manipulated, it can certainly be very safe. And I'm assuming most chiropractors understand which patients are candidates or not. But when you go to someone to manipulate you, whether it's a massage or whether it's a chiropractor, and they're doing the work, you're going to feel great temporarily. But then that's it. It's temporary. You have not exerted your body through any significant stressor to have your body stimulate a healing response. Versus when you go to a physical therapist, most physical therapists are going to say, you do these exercises, you do these squats, you do this, you do that. And they're guiding you through that process so that you're stimulating your body to exert that effort to then experience the triggering response that results in healing. And so that's why, in general, I tend to prefer physical therapy over chiropractic, because physical therapists are going to give you a program that you can do at home. Now, I think today most chiropractors will do a combination of some manipulation and some exercises. And I think that's probably a good combination. But I think you need to just sit down. If you're going to go to a chiropractor, sit down with them and say, hey, what's the goal here? I don't want to come for 30 sessions, like, how do I do this stuff at home? And that's typically how physical therapy works, is you come up with a home program. And that's what I stress to my patients is you can't just go to therapy once or twice a week. You're not going to get better. You have to go once or twice a week. And then the other 5 days of the week, do the exercises at home, because otherwise it's not enough.
Yeah,
and then for these ring dingers, so I don't know if anyone has seen videos. Essentially, there are these videos that are becoming very popular now on social media where you see a patient laying flat on their back with a chiropractor, and then the chiropractor has a towel wrapped around the patient's neck and then kind of does like a little loosey-goosey, and all of a sudden snaps it and you hear a crack. That's essentially the same thing as cracking your knuckles. I think in a spine that's not arthritic, it's probably very safe, but then you have to have a discussion with the chiropractor so that they, and I'm assuming most chiropractors are going to get an x-ray and see what your spine looks like before they manipulate you in that capacity. It could be helpful for temporary decompression, but usually not long-term, because as soon as you stand up again, gravity is going to take its toll and then cause that disc to compress once again.
So I fully agree. I think that there's a spectrum of quality out there. And I think that, what I tell patients is, if you want to get chiropractic care, that's totally fine. Just please don't do any of the high velocity manipulation, which is the neck cracking, the ring dingers, or, you'll see these videos online where, they're getting their backs cracked. I had a patient recently who had a disc herniation. and I did the microdiscectomy, and she went to what she thought was a physical therapist and was doing great for the first 6 weeks. And the physical therapist turned out to be a chiropractor and did one of these manipulations and herniated her disc again. And she immediately had a recurrence of pain when he cracked her back. And I had to take more disc herniation out that happened right then. So, I think it's really more about the relationship you have with the provider and making sure that they understand, like, hey, you just had surgery, let's be gentle. There are horror stories that can happen with those neck manipulations, especially where people can damage the arteries in your neck, and it can be really catastrophic. So that's why I don't want anybody touching the neck, because even if you get an X-ray, they won't really see the arteries on an X-ray and know if there's an anomaly there. So I tend to be a little bit more conservative with that. But if you have a good relationship and you trust that person and they're really doing a lot more physical therapy work and then some manipulation and deep tissue massage type stuff, I think that's totally fine. The reason you feel better after the chiropractic popping is just like Dr. Tanu said, all you're doing is cracking the knuckles in the back, and that releases endorphins. So you feel really good. And they'll take an X-ray before and after and say, look how straight you are. But the second that you stand up, you're not changing any structural element, so that you're going to have the same curve the second you walk out of the office. And that's why you notice that you may have to start going, instead of once a week for a manipulation, twice a week, 3 times a week. And, it becomes a very routine thing, and it feels good right then, but you start feeling bad pretty quickly after again. So I think that if you find the right person, it can be very effective, but take it with caution, especially if they really want to do some of these neck popping and back popping things.
Wow, that was a lot. That was a lot of information. Oh my goodness. Thank you so much. If we don't have any questions, I know we're beyond the time, but this was just really good. Very good information, especially this chiropractic part as well. If we don't have any more questions, I will close us out. Don't see any more questions in the chat. Nope. Okay. So thank
Danita.
you both for these insightful presentations addressing prevalent spinal and back conditions. And we hope that each of you found these presentations helpful. Always a big thank you to our MedStar team for their collaboration on this important initiative, and thank all of you for joining us. Our replays will be on the Facebook and YouTube pages of both Arc of Knowledge and MedStar. And we hope you'll join us next month for our next installment of Ask a Doctor. Please enjoy your evening and happy holidays to all of you. Thanks.
Happy holidays.
Thank you, guys. Happy holidays.
Thank you. That's great.